All right. Good afternoon, everyone. My name is Yair Blumenfeld, and I'll be talking about normal and pathological fetal growth in twin gestations. And I want to thank the organizers for the opportunity to participate in this wonderful symposium. I have no conflicts of interest to disclose related to this presentation. My goals for this presentation are to cover the following topics. We'll talk a little bit about fetal growth in twins and how it compares with singletons. I'll need to take a little detour and go back to what the definitions are of actual fetal growth restriction and its associated conditions. We'll talk about the management of fetal growth restriction, especially as it relates to chorionicity, and then a little bit about potential treatments and prevention strategies in FGR in twin gestations. So, in thinking about sonographic assessment of fetal growth in twins, the first question that has come up recently is whether twin-specific growth charts should be used to assess normal versus pathological growth in twins. And this is a concept that sort of has been raised over the last couple of years. And so, in looking at, first of all, birth weight and comparing twins to singletons. So, again, in this particular graph on the left, we have birth weight, not estimated fetal weight. And the x-axis is gestational age, excuse me. And what you see is the upper line is singletons, and the four dotted lines are in twins using different curves that were collected over the years. You can see that at approximately 29 weeks, again, purely based on birth weight, you can see that there's this divergence between singletons and twins. For some reason, twins grow at the same rate up to about 28, 29 weeks, and then sort of diverge from singletons. This is purely by weighing the neonates. Similarly, when looking at the estimated fetal weight, similar figure on the right-hand side, where you have a sonographic estimation of the fetal weight, you can see that similarly at about 28 weeks, there's this divergence between the singleton curve, which is the upper black line, and the variety of twin curves, which are dotted there. And so the question is, should we be using, different curves to assess whether something is normal or pathological in twins? Stratifying by chorionicity, in this particular figure, you can see the singleton in the blue line, dichorionic twins in the solid line, and monochorionic twins. You can see that even within twins, there's a little bit of a difference between simply the growth of monochorionic twins versus dichorionic twins. The way we calculate estimated fetal weight is by measuring a variety of structures within the growing fetus, including the biparietal diameter, the head circumference, the femur length, the abdominal circumference. And what we see in this particular figure is that it's really the abdominal circumference over time that is the difference between singletons and twins. So it's not that twins necessarily have a different size head or anything else. It seems to be the abdominal circumference that is really driving this difference for the most part. And so we have a few questions. What is fetal growth restriction to begin with, and how is it different from SGA? What is the risk of FGR or SGA in twin gestations, and is it different from singletons? How accurate is our ultrasound when estimating fetal weight in twins versus singletons? And are twins really inherently different size than singletons? Are they meant to be different, or is this something pathological that's going on? And do they have the same growth potential? We know it's this phenomenon in the third trimester. Is it that they have the same growth potential and something goes awry, or did they have a different growth potential early on in the pregnancy? And we'll try to answer some of these things. And should we be using twin-specific growth curves so that we're not over-calling this idea of a small twin when using a singleton growth curve? So first of all, how accurate is our sonographic estimated fetal weight? And I only included, a few papers here. Obviously, the literature is chock full of studies, but in these few papers, just to highlight, it seems like the estimated fetal weight accuracy, not just in the setting of FGR, is maybe slightly decreased compared to singletons, but not by much. The presence of fetal growth restriction in either twin does not necessarily increase the percent error, meaning we're not necessarily affected by the diagnosis of FGR. And in most studies, there was really no difference by chorionicity. So it's not that the sonographic accuracy is more significant if you have dichorionic or monochorionic twins. And I think this is important to understand. I think the greatest controversy is related to nomenclature, meaning what is fetal growth restriction and what is small for gestational age. And I think to add to the controversy, it's not that people don't necessarily know the difference, even the guidelines when we look around the world are quite different. So on the left, I included the ISWOG guidelines, which is what the most of the world uses in terms of their obstetric guidelines. And then on the right, we have the Society for Maternal Fetal Medicine, where there's overlap with ACOG as well. So just to show you, if we look at ISWOG, the way they define a fetal growth restriction is a fetus failing to reach its genetically predetermined growth potential. So again, so it's not that you have a fetus that is less than 10th percentile that is FGR. You can have a fetus that is 13th percentile, but its growth potential was meant to be 50th. So imagine a fetus where the parents are very large. Clearly, that growth potential is much higher than 13%. ISWOG defines SGA as either a fetus or a neonate weighing less than 10 percentile. So here, according to ISWOG, and really in much of the world, SGA is really a mathematical formula where FGR is more of this sort of philosophical definition. And this brings up the concept that an SGA fetus may be small, but not necessarily at increased risk. So, an SGA, not every fetus or neonate less than 10 percentile is pathological, whereas a fetal growth restricted baby could be greater than 10 percentile, but really it suggests this pathological process. And then we compare that with SMFM, and according to SMFM, FGR, it's not this philosophical definition. It's really a fetus with an estimated fetal weight less than 10th percentile. So almost incorporating that SGA from ISWOG, whereas SGA is a newborn. So according to SMFM and ACOG, the difference between FGR and SGA simply has to do with whether or not you're talking about prenatal or postnatal. And here, sorry, let me just move this. Fetuses with FGR, not always SGA at birth, and SGA neonates have often not been diagnosed with growth restriction, so suggesting that there's some inherent inaccuracy when it comes to ultrasound. So we can see differences there. Um, in terms of the actual definitions, at some point, even though ISWOG has this philosophical definition, they do want to use some sonographic markers to help us determine FGR, or at least suspect FGR. And they divide this. I know it's kind of small print. You don't really have to memorize this unless you're spending a lot of time doing ultrasound. But ISWOG does define early versus late, and they use a cutoff of 32 weeks. And if it's after 32 weeks, what they do is they have this combination of the abdominal circumference and other Doppler indices, and it can get quite confusing. They use uterine artery Dopplers and things that we don't necessarily use in the United States. But the concept here globally is that ISWOG really wants to identify sonographic markers of severe disease when defining fetal growth restriction. And then we look at SMFM, and for them it's simple. Estimated fetal weight less than 10 percentile, or the abdominal circumference less than 10 percentile. No sort of distinguishing by 32 weeks and no incorporation of uterine artery Dopplers or anything else. So really very, very different definitions, very, very different sonographic criteria for making the difference. And so it can get quite confusing depending on where in the world you practice. Now, ACOG incorporated, of course, there's a lot of overlap between ACOG and SMFM. And you can see that the definitions here essentially mirror SMFM. And here, the fetal growth restriction will be used to describe fetuses with an estimated fetal weight or abdominal circumference less than 10 percentile, whereas term SGA will be used exclusively to describe newborns. So again, ACOG is similar to SMFM. FGR is a fetal issue. SGA is a neonatal issue. Both of them are simply a categorical cutoff of 10%. What about weight discordance? Many of you who do ultrasound or refer for ultrasound will have the report come back and it says, well, twins aren't necessarily less than 10th percentile, but there's this percentile discordance. To add insult to injury, this is a paper that you don't have to look at these curves or understand them, but This is an analysis of a very large cohort, and they looked at different growth patterns in dichorionic and in monochorionic twins. And this group saw different growth patterns or discordant patterns. When I look at a figure like this, whether it's the dichorionic twins or the monochorionic twins, where it's clearly all over the place, this tells me that there's no sort of silver bullet here to help me. And it's a very, very murky field. At least that's the way I look at it as a clinician. Um, Again, going back to this concept that things differ depending on where you practice, I included here guidelines from the US, Canada, UK, France, Germany, ISWAG, FIGO, etc. And if you look at the lowest rung there, the lowest row, I included the discordance cutoff. You can see that different societies in different countries use different cutoffs to sort of raise their antennas. I also included individual guidelines from these countries, and you can see differences in the definition of FGR and dichorionic or monochorionic twins. And so really, really murky. Um, Regardless of what you're going to do and how you're going to define, let's assume, most of you do practice in the US, and my apologies for people who are listening to this talk from international areas, but let's assume we incorporate the ACOG and SMFM guidelines. What are the implications here in twins? And I want to just raise a few points, and I would focus less on all the busy numbers and more about the headings here. So essentially, in this particular study, it's highlighted that when we diagnose SGA in twins, it seems like there's decreased neonatal risks, but higher maternal risks when compared with SGA in singletons. And what do I mean by that? So if we look at the top rung here and we look at SGA at 10th percentile, and this was, in neonates, we can see that, one second, let me do it this way. Okay, so the top part here are the maternal risks, and the bottom part are neonatal risks when neonates were less than 10th percentile. And here we compare singletons and twins. And so you can see in these maternal risks, whether it's cesarean section, preeclampsia, abruption, PPH, etc., there's a higher risk in twins than singletons when one of the twins is diagnosed with SGA. However, when you see the neonatal risk, including RDS, hypoglycemia, jaundice, IUFD, etc., there's a higher risk in the singletons globally than there are in twins. And what that means to me, and this is sorry, and this is especially true when looking at less than fifth percentile, that it suggests again that there is probably some overcalling of SGA in twins rather than singletons. To add to that sort of concept, when looking at placental abnormalities, when twins are diagnosed with SGA versus singletons, placentas of singletons are much more likely to have a placental issue than twins. Again, suggesting that SGA twins, because we're not as good as identifying small babies, it's probably not necessarily a placental function, but possibly an overcalling function. And then finally, to really drive that point home, what happens when you start using twin-specific growth charts rather than twins to identify true pathology? In this particular study, you can see neonates that were born small, and then this was using a twin chart, and this was using singleton chart. And they stratified both by estimated fetal weight or by birth weight. And you can see that the prediction or the likelihood of having an adverse outcome if you diagnose an SGA baby or a fetus with a twin chart, the likelihood is much, much, much higher than you do with a singleton. So you can see in this case, whether you use the estimated fetal weight or the birth weight, using a twin-specific chart is much more predictive. I think it's important to remember that fetal growth restriction is not purely a placental issue. And I know the first thing we ask ourselves when we have fetal growth restriction, we say, what's the Doppler? What are the uterine artery Dopplers? Clearly that's a sign of placental disease, but we have to remember all these other things. We have to think about maternal issues, we have to think about fetal issues, and of course, other placental problems and idiopathic. And I think we are seeing a fair amount of data come out recently about the benefit of performing, or at least doing some additional genetic studies, certainly in singletons, maybe even in twins, to identify underlying genetic causes, and it's not all placental. So, in going back to our initial questions and trying to answer those, what is the risk of SGA at birth in twins versus singletons? Well, it's higher. Most twins will be diagnosed with smaller babies. How accurate is our ultrasound? Well, slightly less accurate, but not by much. And there doesn't seem to be a difference by chronicity. Um, are twins just inherently smaller than singletons? Well, not initially, but any difference in the third trimester needs to be elucidated. And should we be using twin-specific growth curves? Well, it's a little controversial still. There's no real, certainly in the US, I think it's really being incorporated more widely around the world, but there's no final guidelines to use twin-specific growth curves or which curve to use altogether. Thinking about this concept of fetal growth restriction that ISWAG uses, which is a fetus that fails to meet its growth potential. When we use nomograms and growth curves, we have a cohort that we're looking at. Obviously, I'm being a little facetious here using sheep. And so we calculate what the size is supposed to be based on a bunch of sheep. And then we say, okay, how does our specific sheep fit next to all these sheep? Well, in this era of personalized medicine, I have patients, actually, a patient asked me yesterday, what about, I'm from this ethnicity or this cohort, does it fit? And of course, the answer is no, that we don't have cohorts, or at least readily available cohorts for every different ethnicity, country of origin, etc. So there are limitations here to these nomograms. And this really brought up this concept of individual growth assessment, or IGA or IGAP. And this was brought forth almost 15 years now, where the thinking is this: if we're going to try to figure out what an individual growth potential is, rather than using nomograms and trying to figure out where our fetus lies relative to that nomogram, or our neonate relative to that nomogram, what if we could do sort of a bunch of early ultrasounds, come up with some curve, and then identify later on where the estimated fetal weight is relative to the curve that we expect? And that's kind of the concept, where the fetus itself is its own control, meaning you develop this nomogram based on the initial growth, and you can see whether that fetus reaches its own potential. Well, it turns out you can do that. And this was a paper published now, 7 years ago. Russ Dieter from Baylor really was the big proponent of this concept. And you can see in singletons here, when you're looking at these different measurements, this one's the head circumference, abdominal circumference, femur length, and the total EFW. You can see some early ultrasounds. They create a projected growth. That's the blue line there, and similar for abdominal circumference, et cetera, estimated fetal weight. And then you do additional measurements in the third trimester and you say, okay, normal or pathological based on this growth trajectory that we would expect. And so this is the concept in singletons. And when Russ Dieter was looking at that in singletons, not only did he come up with a concept, but he said, well, not every growth restriction is similar. And he came up with at least 5 different growth patterns, something that is progressive starting early on, and something that is later on, and something that is early on and persistent, something that recovers, different kinds of patterns, so that not every growth restriction based on individual growth potential is the same. Well, we collaborated with Dr. Dieter, and we said, okay, what about twins? And we used our own data, and this was published several years ago, where we calculated our own twins, and we said, okay, can we do that as well? Can we come up with a calculated sort of growth potential for twins? And it turns out you can do that as well. And it turns out that you can identify whether or not a twin was meant to reach its growth potential, and we can come up with different growth pathologies as well in twins. Don't worry necessarily about all this math, but the point of all this math in this table is really the heading here, that when you do those kinds of analyses, not only can you identify different pathological processes relative to the growth potential, but you can actually determine whether or not twins or singletons have similar growth potentials based on the early ultrasound. And using mathematical calculations, it turns out that difference in the slope, or difference in the growth that we see in the third trimester, is not because twins and singletons have different growth potential. It's not that they were necessarily meant to grow differently early on. Something in that third trimester is different between the two. And then using the data and coming up with the different pathologies, we found that in our monochorionic twins and dichorionic twins, these were the rates of fetal growth restriction that we saw based on IGAP. Again, quite high, 30% and 22%. We did see different growth patterns as well. We were slightly less overcalling compared to traditional methods, meaning we had lower rates of fetal growth restriction. This was based on singleton nomograms in our twins, not twins. But the difference wasn't statistically significant. But we were able to make the diagnosis later, meaning that using singleton growth curves, maybe we're overcalling a little bit too early, maybe doing some additional scans, possibly increasing anxiety. And so we need to do a better job of identifying true pathology. So to summarize all this together, putting all this together, what is really the best reference? Is it really the singleton nomograms, the twin nomograms, the co-twin, or growth potential? Time will tell, and there's more to be done there. Let's talk a little bit about selective fetal growth restriction in monochorionic twins, because this comes up a lot. Um, I submitted my slides, and I know the organizers are going to kill me, but yesterday I got this announcement that the Green Journal just published, not even in print, this updated management in monochorionic twins. I urge everyone to read it. Lynn Simpson's fantastic. She's from Columbia. You can see it's obstetrics and gynecology, and there's really not even a date yet. This is only online. But I went through this just to see if there's something I'm missing. And the first thing that Lynn included in her analysis is really the essential role of ultrasound in identifying chorionicity and placentation is paramount. Couldn't agree more. And the reason, of course, is that our monochorionic twins have much, much, much higher risk for all these abnormalities that we see on the left-hand side. And germane to this talk, of course, is fetal growth restriction. And the reason for that is this concept that about 15 or almost 20 years ago, Eduardo Gratacos in Spain came up with this concept of different types of selective fetal growth restriction with monochorionic twins. And so he came up with these three types: type 1, type 2, and type 3. Type 1 is when you have selective fetal growth restriction with normal Doppler indices. Type 2 is actually persistent absent or reverse indices, and type 3 is intermittent. So it's sort of counterintuitive. It's not increasing severity. So really, type 2 is the worst, and type 3 is just intermittently absent or reversed. And so we kind of looked at our own data. We didn't publish this, but we looked at our own data just to see what's the incidence of this type 1, type 2, and type 3. So a couple of things. First of all, we categorized, based on these ISWA guide, the incidence of FGR and monochorionic twins using these different ISWA guidelines and the SMFM. So first of all, you can see first just by assessment of ultrasound, if we use these ISWA guidelines, we only had 14% FGR. If we use these guidelines, we had 9%. And if we use the ACOG and SMFM version, we had 36%. So again, the ultrasound, which criteria used to define FGR is problematic. And then we looked at the different subtypes of type 1, type 2, and type 3 that we had in our cohort, and we're able to calculate sort of the positive and the negative predictive value of having a fetus less than 10th percentile. The reason that this classification by Gratacos made such headway and that a lot of people are incorporating it is really the following. So in addition to just coming up with this quirky classification system where type 2 is really worse than type 3, he then looked at the outcomes of some of these twins. So specifically looking at unexpected IUFD, intraventricular hemorrhage, and brain bleeds in these neonates. So not surprisingly, type 1, those with normal Doppler indices were pretty normal. Type 2, the really sort of bad ones, all of a sudden you're starting to see some hemorrhage, you're starting to see some parenchymal brain bleeds, etc. But this was really the surprise. These type 3 that just had intermittent abnormal Dopplers, here you can also see this sort of intraventricular hemorrhage, and you can also see this brain bleed and also some IUFD, suggesting that it's really a labile sort of group. And this really propagated many studies and subsequent areas of inquiry, in particular because we know that the risk when you have severe fetal growth restriction, one of the things that can happen is, of course, demise of the twin. And if you have demise of one twin, because they share vascular anastomoses along the placental surface, you can have either anemia in the surviving twin, which we can see on the right-hand side, or worse, demise of the co-twin. And if you have anemia in one of the twins, the next thing that you're going to see in the coming weeks is really abnormal brain development. So we're really trying to avoid a demise when we have monochorionic twins. And you can see a couple of different CNS ramifications when you have a co-twin demise with monochorionic twins. Um, More recent data looking at close monitoring. So this is, I showed you the original data from Gestations and sort of the outcomes. This particular group below was conducted a study several years later saying, okay, so now we know these risks now, we know about type 1, type 2, and type 3. What if we perform closer monitoring? Can we change the trajectory? And the answer is kind of yes. First of all, this is the number that they had. You can see not very large numbers. They had 26 cases of type 1 and 22 of type 2 and 12 type 3. And you can see the gestational age of the birth, not surprisingly, much, much, much higher rates of delivery before 24, 30, and 32 weeks in this group with the absent or reverse Doppler flow. But really, the crux of the point here are the outcomes. So again, this is type 1, this is type 2, and type 3. And you can see the outcomes of abnormal CNS outcomes. Not surprisingly, in type 1, you don't have a lot. Not surprisingly, in type 2, you still have some. These are the ones with the absent or reverse. But really, with close monitoring, you can sort of really reduce the adverse outcomes in type 3 FGR, meaning those monochorionic twins where you have intermittently absent or reverse. If you monitor them closely and deliver them at appropriate gestational age based on indications, you can hopefully avoid a lot of those adverse events. Given the abnormality associated with co-twin demise and sort of the risk there, what can we do to minimize that if we have a case of severe fetal growth restriction? The first thing is a controlled feticide using radiofrequency ablation. We use this approach to sort of clog or ablate the cord insertion of the smaller twin. And the idea is to do that and to block the blood flow that could go from the surviving twin to its co-twin. Some people use bipolar coagulation. You can see that these are the outcomes or the complications related to radiofrequency ablation. I just included a few of the studies here. The cohort size here, these were monochorionic twins with selective fetal growth restriction. And then you can see that the survival of the co-twin is not even close to 100%. And really the complication rate is probably around 15%, give or take. Meaning, and this is very, very different from selective reduction in, let's say, dichorionic twins or triplets that we do in the first trimester when we don't have monochorionic twins. So again, using RFA is quite a little bit riskier. And then some people are actually using laser ablation to really ablate the anastomosis, similar to twin-twin, to sort of protect the surviving twin. I think this is done in not so many centers. Most centers use RFA or bipolar coagulation. We can gloss over this one. So what about, given all of that, given all the different definitions and the different risks and the different outcomes based on surveillance of monochorionic twins and et cetera, what are the recommendations here? So the crux here is I included the ACOG recommendations. You can see this in the syllabus. ACOG appropriately divides this between monodi twins and didi twins. Ultrasound, you can see in monochorionic twins is very common, usually every 2 weeks, mostly because of TTTS. And then delivery timing for uncomplicated twins is here, with isolated FGR is here, and then with diti twins later on. I'm not going to go through all this. This is a SMFM consult series related to monitoring of twins, related to FGR. And if you think this is complicated, here's the ISWA guidelines. You certainly don't need to memorize this one unless you're practicing somewhere around the world that incorporates that. But you can see these are the recommendations once you diagnose fetal growth restriction, very, very close surveillance, a lot of Doppler indices. But I just wanted to highlight how convoluted the paradigms can become. But really, if we talk about type 1 monochorionic twins, those with normal Doppler indices, really they tend to develop later in gestation. They tend to have favorable outcomes. There tends to be lower discordance. The risk is usually very low. One study had a little bit of a higher risk, but really like it's as close to zero as you can get. And usually expectant management with close observation is reasonable. And again, ACOG recommends delivery between 32 and 35 weeks for those. When you have type 3, those with labile or intermittently absent or reversed Doppler indices, those are unpredictable. You got to really, really keep a close eye on them. Demise of one twin has been reported to be quite high. The mean gestational age of delivery is around 31 to 32 weeks. There are really no established treatment options. I even checked the ACOG guidelines today. They don't distinguish intermittent from persistent, absent, or reverse. A lot of close surveillance, some likely inpatient. And then finally, with type 2 monochorionic twins, those are with persistent, absent, or reverse. Um, the deterioration is quite high over time. Mean gestational age of delivery is usually around 28 to 30 weeks. If you have demise of one twin, you're really, really in a bad spot, associated with a lot of brain parenchymal abnormality. And really, the delivery recommendations to individualize. I don't want to necessarily give you a number because we've certainly delivered reverse flow even as early as 25, 26 weeks. But ACOG suggests that if you can get to a reasonable gestational age, meaning 30 to 32 weeks for reverse, or 32 to 34 for absent, meaning you should not be watching reverse after 32. You should not be watching persistently absent after 34. But most of the time, these deliver before those, at least in my anecdotal experience. Um, there is an SMFM slash ACOG sort of checklist that you can do, counseling. I just want to make sure that you guys were aware of that. I'm not going to go through that. And then finally, what about prevention strategies for FGR in twins? The people are looking into this, a fair amount of data on this. Aspirin, at least at this point, has not been shown has not been shown to improve birth weight in twins, meaning universally, like a universal effect where you have twins that are otherwise uncomplicated and you say, okay, let's give them low dose aspirin for benefit there. Not a lot of proven benefit there. And I wanted to include all of the international guidelines about maternal caloric intake because this comes up in all of our clinics. You have a new twin patient, and they ask you, how much should I be eating? How much do I need to have added intake of X, Y, and Z? I included all the guidelines here. You can see a big fat zero. So in summary, the growth patterns of both physiologic and pathologic twins is very different from singletons, predominantly in the third trimester. We still have some questions regarding FGR definitions, certainly when we compare around the world. In the United States, yeah, we use that more simple ACOG and SMFM definition. For those of you guys practicing elsewhere, you have your ISWAG definitions or some national guidelines. The most important thing in the first trimester is to identify the chronicity, and because the surveillance is going to vary widely. There's really lack of consensus about delivery timing when you have FGR in twins. I think, and this is just hypothesis, that we're going to start to see some twin-specific growth curves. I think there's going to be a lot of discussion about which one to use, but we're not quite there yet. And I still like this concept of IGAP, this concept where an individual fetus serves as its own control. I hope there's more studies on that, and I hope we can incorporate it in some way because biologically it makes, to me at least, more sense than using nomograms, especially with the way that we try to think about personalized medicine, and we need a lot more data. So I want to thank you all for listening. I know it's the end of the meeting. I know it's the end of the day. I know how hard it is. And I'll stop here and I'll pass it on to my colleague, Dr. Litt.
Thank you so much, Dr. Blumenfeld. And thank you to the organizers for the invitation to come and speak with you today. I will be picking up the conversation about fetal growth restriction and talking about outcomes, both early and later outcomes on physical growth, other morbidities, and neurodevelopment among infants who are experiencing fetal growth restriction. I have nothing to disclose. So for the next half an hour or so, what I'd like to do is to talk about fetal growth restriction and how it differs from small for gestational age status, although, as you just heard, there is some controversy about that. The second objective is to describe the impact of growth restriction in areas of physiology and organ system functioning in the newborn period. And then third, to move on to areas of health and development after NICU discharge and enter into early and later childhood as children grow and develop. So first, I will speak very briefly about defining fetal growth restriction, because you just had a wonderful and rather robust discussion about that. This again is another the set of guidelines, the international guidelines, which are, as Dr. Blumenfeld mentioned, rather complex and perhaps not applied universally. So I'm certainly not here for those of us practicing in the US, but it defines for us, as I've sort of come to learn about it, sort of the difference between early and late onset restriction of growth in fetal life after 32 weeks as being a different and more common than earlier onset. And of course, here in the US, as was mentioned just prior, we typically use a much less complex definition. We also think about being symmetric and asymmetrical growth restriction as well. And so less common is symmetric in 20–30% of cases. And it's thought to be related to adverse intrauterine conditions beginning early in life, in fetal life. It can be associated with chromosomal abnormalities such as aneuploidies, infections that are experienced in intrauterine life, and certainly severe fetal malnutrition can also cause early and symmetrical growth restriction. Contrast that with asymmetrical growth restriction, where or head sparing is more common in these cases. The timing is thought to be later in pregnancy, but not always, with relative preservation of head circumference and brain growth. Preeclampsia is a well-known sort of precursor to this, as well as chronic hypertension. Again, as my colleague went over, there are several reasons why a fetus may experience growth restriction, having to do with themselves, the fetus, and thinking about genetic abnormalities and syndromes and infections. There are maternal reasons that can cause growth restriction as well in terms of chronic disease, substance use, multiple gestations, as we just heard about, and poor nutrition, and then problems or disorders of placentation or the umbilical cord. And just to round out, I certainly don't want to get into the controversies or the discrepancies around what is and is not growth restriction compared to small for gestational age. Certainly for those of us practicing in the US context, we think of growth restriction being something that's affecting the fetus, and being small for gestational age is something that we as neonatologists will diagnose and assess after the infant is born. So to move on to think about what is the impact of growth restriction early in life, so on physiology and organ functioning in the newborn period. Well, first, just to a brief note about the timing of delivery. I'm certainly not an obstetrician or maternal fetal medicine specialist, but thinking about delivery and particularly around singletons, and not the twin situation, but recognizing that growth restriction alone isn't an indication for delivery, and the optimal timing really has to do with the situation, the health of the fetus, and the health of the pregnant person as well. I mentioned this as a pediatrician and neonatologist and not an obstetrician because it impacts the timing of delivery impacts the gestation at birth. And we do know that being growth restricted as a fetus really is a risk factor for being early. And these are some data that show us this from an international center looking at fetuses with weights under the 10th percentile and the risk or likelihood of being born early. We also recognize that being growth restricted, particularly early onset, so early in fetal life, increases your likelihood of actually not surviving to delivery. This is a meta-analysis that reports from multiple studies, 25 studies, in fact, reporting nearly 3,000 pregnancies and looking at the risk of stillbirth or antenatal death, although recognizing that the quality of the evidence from these was low. Once the infant is born, we know that there are several different risks or risks for several different types of morbidities that we need to think about. The first is thinking about the impact on the cardiovascular system and thinking about hypotension, persistent fetal circulation or PPHN, structural heart changes and remodeling in terms of the vessel wall and cardiac functions. Respiratory symptoms are also common, and we can see increased need for respiratory support for meconium aspiration syndrome related, we think, to increased risk for fetal distress among infants who are growth restricted, and pulmonary hypertension and hemorrhage and BPD. Neurologic morbidity is also related to being growth restricted, as we just heard in the prior talk, particularly thinking about the risk of IVH and PVL, white matter injury, EEG abnormalities, and associated seizures. And lastly, sort of this others category here is sort of a catch-all, but we think about babies having risk for hypoglycemia and hypocalcemia. They can be cold related to their small size. We think about sepsis and jaundice and polycythemia, among many others. And we know that being born growth restricted also increases your likelihood of needing to be admitted to either special care or nursery or a NICU after birth. I wanted to take a few moments to think about just a few of these. We certainly can't cover all of these in any depth, but thinking about feeding, particularly as it relates to our growth restricted infants who also are born early, it's something that we as neonatologists spend a lot of time thinking about and perhaps fretting about. And I think it's really interesting to look at what the data tell us about the risks to early enteral feeding. And there have been actually a number of different studies and trials, in fact, looking at the timing and the types of feeding that we initiate for our infants who are growth restricted. The first one that I'll talk about is this Evers trial that looked at um, rates of surgical neck in infants with growth restriction, which are certainly higher. The time to full feeds, to achieving full feeds, is longer for infants who are growth restricted, and length of stay was longer as well. This is increased for babies who were born preterm, and in fact, the likelihood of having delays in feed and any feeding related complications is compounded by early preterm birth. And you see here that neck and SIP, or spontaneous intestinal perforation, are much more likely in infants with growth restriction, preterm birth, and abnormalities of their umbilical Dopplers. We know that optimal catch-up growth is important for proper development, both of the brain and neurocognitive development, but then also just your general health. We'll talk about what catch-up growth means in a minute. We know that excessive catch-up growth can be detrimental to one's health over time. There are increased nutrient deficits associated with intrauterine malnutrition, which may or may not be the causes of your growth restriction, and we need to be attentive to that. That can also impact later postnatal life. Again, the risk of neck is a concern. Delayed feeding is common. And as I said, we tend to advance feeds much more slowly for infants with growth restriction. But how concerned really should we be? So in this trial, 404 infants who were born early, I'm sorry, that should show below 36 weeks and birth weight under the 10th percentile, so their SGA. And had abnormal antenatal umbilical artery Dopplers. They were randomized to early or later feeding, as described there. And they found that infants who would advance more rapidly to full feeds if we started earlier, even so they tended to tolerate feeds better. And for the infants who didn't tolerate their feeds so well, it really was gestational age dependent, with infants born under 29 weeks having a bit more difficulty. In another study of 133 infants with gestational age below 37 weeks, and again, birth weights below the 10th percentile were randomized again to early and late feeding. And in this small study, they found that incidence of neck and feeding intolerance weren't really different between those two groups, which I have to say is reassuring to me as a clinician. In this last study of 184 infants who were born under 35 weeks, some of whom had abnormal umbilical artery Dopplers and others who didn't. We found that infants, or they found that infants with uh, Doppler abnormalities tended to start feeding later, advance slower to full feeds. But after adjusting for this, for other confounders, the Doppler flow didn't seem to actually have an effect. And again, neck rates were similar between both groups. Next, I'd like to highlight the brain, because that's another area of concern that we have for infants who are born small for gestational age or after fetal growth restriction. We know that early growth restriction is associated with preterm birth, and preterm birth is highly associated with IVH, of course. But there's really mixed evidence on the relationship between fetal growth restriction and intraventricular hemorrhage. This is a study that is a meta-analysis that actually found that infants who were born with fetal growth restriction or small for gestational age, and I will make a note to let you know that these were defined differently in these different studies, but found that there was no increased risk with fetal growth restriction for intraventricular hemorrhage after birth. And this is a study that's also looking at paraventricular leukomalacia or white matter injury. And that also found that infants who are born with growth restriction did not have increased risk for white matter injury either when taking gestational age into account. The last area I'd like to think about is neurosensory development, and particularly retinopathy of prematurity. This is another concern that we often will think about for babies who are born with growth restriction. And we know that risk factors for retinopathy are being born small, under 1,500 grams, being born under 30 weeks gestation, and poor postnatal weight gain. Um, Interestingly, there certainly is a relationship between being growth restricted and need for both having ROP, needing ROP treatment, and having the worse ROP disease compared to infants who are not growth restricted. From one study, which I also found quite interesting among monochorionic twins, that the twin who was growth restricted actually had 3 times the odds of having ROP compared to their normally growth twin. The last area that I'd like to spend some time thinking about is identifying some threats to health and development after NICU discharge that's posed by fetal growth restriction. So again, I come back to thinking about the different areas, the different organ systems, and cardiovascular health, thinking about long-term hypertension, ischemic heart disease, stroke, and atherosclerosis. Respiratory system, excuse me. Infants who are born with growth restriction have higher rates of asthma and reactive airway disease and lower lung function, pulmonary function over time. There is documented neurologic morbidity, which we'll talk a bit more about in more depth, thinking about neurodevelopment, behavior, learning, cerebral palsy, later dementia, and mental health diagnoses and problems. And then again, this last other sort of category, this bucket, thinking about both failure to thrive and being small or thin or stunted, having stunted growth, but then also obesity over time. There can be immune dysfunction and dysregulation, problems with bone health, metabolic syndrome, which we'll talk about again, renal issues, hormone problems, some reports of higher cancer, although that's a bit unclear. And then shortened lifespan, that is also a bit unclear, and I think is quite confounded by the other chronic health problems um, that I've noted. So I'd like to think about growth because that really is the topic of the hour. And to think about first catch-up growth, which I mentioned at the beginning of the talk, the catch-up growth is defined as a period of accelerated growth after a period of growth restriction. And it's defined by reaching a certain percentile or a change in parameter over time. And just like the definition of growth restriction itself, catch-up growth has many definitions depending on which researcher, which institution, and actually which country you're living in. So it's a bit of a catch-all term for many different things. But we know that the vast majority, and some studies have shown up to around 80 to 90% or so of infants with fetal growth restriction are thought to catch up to peers by childhood. I share here with you a figure from a paper from a few years ago that shows catch-up growth, or sort of the percentage of children with growth restriction who have had catch-up growth by school age. You'll see here on the very left that and here it's SGA, and it's actually not fetal growth restriction, but here they're looking at the baby's weight being small for gestational age, the definition. And so these are different ways of defining that by percentage of birth weight for gestational age. The age of the child, and what the catch-up growth definition was. Is it a difference in terms of what their growth is doing, or is it percentile based? And then the country where they live. And you'll see that there's a variation in terms of the number of children who have, quote unquote, caught up to where they should be by the various ages here. From this study that's more recent, compared children with fetal growth restriction to um, typically grown peers of the same age. And what you're seeing here in these two different graphs are the difference in growth parameters. In the figure on the left is the difference in height, and on the right is the difference in BMI. And it's the difference in those two parameters between the children with growth restriction and the children without. And you see in early childhood, in the first few years, that difference between those parameters, right, between those two groups of children, drops dramatically. And it stays, it's pretty low over time, showing that the catch-up growth, if it's going to happen, happens in the first 2 years. And certainly by age 2, the children who have caught up or are meant to caught up have already done so. What do we know as a relative to the rate of catch-up growth and outcomes? We know that catch-up growth for children between 0 and 2 years of life, the rate of catch-up growth matters. So among children ages 0 to 2, they tend to be fatter or heavier and have more central fat distribution at 5 years of age if you've caught up early and more rapidly. We know higher weight gain in weight for length in the first 3 months of life is associated with higher prevalence of metabolic syndrome, actually in early adulthood. And that rapid adiposity gain in infancy and continued overweight and obesity are associated with, of course, greater blood pressure in young adulthood. So we have some data now, sort of to summarize this set of studies, showing us that the more quickly you catch up in terms of your weight and growth, it actually might not be of a benefit to your long-term health in terms of your metabolic health and your risk for obesity and obesity-related illnesses like hypertension. Interestingly, though, the data are not so certain, and so here I share with you another a study. This is a study from a bit longer ago, a few years ago, showing growth and adiposity outcomes at age 11 among children born moderately or moderately, I'm sorry, moderately or mildly growth restricted, appropriate for their gestational age, or large. And actually, their BMI and their fat mass index associated with kids who are small at birth is actually lower at age 11. Um, this, though, doesn't really take account what kind of what kind of catch-up growth they may or may not have had early on in life. And here is another figure from a meta-analysis from 2023 that again tried to answer this question, right? Because we have this sense that children who are born with having had growth restriction are at risk for obesity. And here we have a meta-analysis that shows body mass index z-scores, again, in early childhood, that actually show us that children's body mass index tends to be higher for children who didn't have growth restriction or were not small for gestational age. And again, unfortunately, these terms were used a bit interchangeably, so it makes it a little difficult to draw conclusions. And we again don't know about the rate of catch-up growth for these children. So I present these few studies to share with you that I think the jury is still out a bit about the impact of growth restriction or being small for gestational age on your eventual risk for obesity. And it really does seem like it's related to the rapidity in which you sort of catch up or get back to where you maybe should have been on your growth curve. Cardiometabolic health certainly related to your overall size and particularly later in life. We know children who are born growth restricted or at least are worried about this group of children for two different reasons. One, there's this idea that that intrauterine deprivation of nutrients can actually sort of cause abnormalities in your organs and particularly the beta cells of your pancreas and your kidneys and your cardiac myocytes that can cause organ hypoplasia and then dysregulation down the road in terms of your cardiometabolic health. There's also then this catch-up hypothesis sort of related to being born small, and then there's this compensatory growth during the first years of life, sometimes maybe too fast, as I've mentioned, that can lead to excessive body weight, fat accumulation, and that can lead to obesity, lipid disorders, insulin resistance, and cardiovascular disease, among other chronic health diseases of adulthood. There are reports that infants who have growth restriction or who had growth restriction in fetal life are at risk for systemic hypertension, for atherosclerosis, chronic kidney disease, reduced insulin sensitivity, and eventual diabetes. And again, though, it really isn't clear, is it the growth restriction or is it the postnatal environment and catch-up growth that's going to lead to these chronic diseases of adulthood? This figure is a bit busy, and it comes from a nice review paper thinking about the possible influences of growth restriction on health over time. And I do think it's interesting to note that the likelihood of death from coronary heart disease, even before 65, so a premature death, is higher for infants who are born smaller. And this is another schema from a nice review paper as well that really tries to pull together all of the science on our thinking about the impact of fetal health on life course health trajectories over time, thinking about particularly the impact of growth restriction on cardiometabolic health, on hormone regulation, and then metabolic pathways over time. I want to switch gears here for a moment to think about neurodevelopment, which is my particular area of focus and study, and thinking about the impact of growth restriction on childhood neurodevelopment. So this is a systematic review that aimed to synthesize the evidence of fetal growth restriction on development. The population was infants with growth restriction and outcomes were measured at 6 months, between 6 months to 3 years of age, so infancy and early childhood. They've reviewed 700 studies and included 16, and they found that poor neurodevelopmental outcomes were related to growth restriction in 11 of those studies. In 10 of the studies, they found poor motor scores. In 8, there were cognitive delays, and in 7 of the studies, they reported language delays. Other delays included those in social development, in attention, and in adaptive behavior. Here are 3 different forest plots that show the summary of the data from the meta-analysis, thinking about cognitive and behavioral outcomes after intrauterine growth restriction among school-age children. On the left panel, we see the effect of cognition at school age with an impact of growth restriction. On behavior as well, behavior scores tend to be worse among children who had growth restriction, as well as diagnoses of ADHD. This is an interesting paper that uses 2 different cohorts from 2 different countries to look at the association between fetal growth restriction and child ADHD symptoms. And you'll see that on the left, rates of ADHD, or the effect of ADHD of fetal growth restriction, I'm sorry, on ADHD in the 2 different cohorts, and those are the 2 different bars with those shades of gray. And you see that there is an effect of growth restriction at baseline, but then the authors added serially the effects of socioeconomic status and social determinants, family psychiatric histories, pregnancy complications, and then maternal substance use. And you see that the rates actually fall down. And that tells us that, yes, there is an impact of growth restriction, but it's likely either founded or mediated by other social or environmental or familial factors. And here is another meta-analysis thinking about age 10 outcomes. And these are infants who are born young, so they're born under 28 weeks, but also had fetal growth restriction. And what the authors found in this meta-analysis and summary of evidence is that there is a signal, and these are adjusted Z-score changes in various aspects of executive function. So I put a few arrows to lead your eye to the areas of executive functioning that seem to be impacted by growth restriction among these preterm infants, thinking about working memory, auditory response and attention, and at the bottom, numeric operations. That certainly caught my interest, recognizing that preterm infants have higher rates of math learning disabilities than their preterm or term peers. And it's interesting to see that those preterm infants with fetal growth restriction actually have an increased risk beyond what their gestational age risk is. And these this is from the same study looking at social development as well. And I put some arrows there to show that the odds of having social awareness and social cognition problems and diagnoses of autism spectrum disorders are higher among infants with growth restriction. So the long-term neurologic complications, there's this paper from a couple years ago thinking about what the authors thought termed brain reserve, or sort of what is the ultimate capacity for these infants long-term over their life course, and taking a really nice life course perspective on the impact of growth restriction, thinking about perhaps in infancy, we have metabolic derangements and reduced cortical growth and hippocampal volume at term equivalent age that has been demonstrated in the literature based on imaging studies. In childhood, there's a reduction of cortical gray matter and some other areas of the brain. There's also some evidence that there's reduced intrahemispheric connectivity among children who had growth restriction in fetal life. And then in adulthood, there are the 2 different cohorts that have noted differences in brain architecture. The one from Norway showed differences in or reduction in brain volume in certain areas of the brain, but it didn't seem to have any effect on IQ. And a group from Colombia showed many areas of reduced volume, but again, no differences in IQ. So it's unclear if these changes, these architectural changes noted in adults with fetal growth restriction really have any impact on their life and functioning. IQ only tells us what they can, or how they're performing on tests. It doesn't tell us much about their functional lives or capacities. So in the last few minutes I have with you, I'd just like to say, or to think about what are the implications of care um, for children who are born with fetal growth restriction, thinking about both the NICU and beyond, right? So we know that there are going to be, there are important impacts of fetal life on outcomes. But we also recognize that those outcomes aren't predestined, right? And they're going to be impacted by environmental influences over time. So growth restriction, gestational age, and birth weight at birth aren't truly destiny. And I think it gives us what I presented with you today gives us some opportunity to think about how can we best support children, both when they're in the NICU and over the life course as they leave. And of course, the first thing to do is to think about prevention of growth restriction in the first place, and thinking about how to optimize fetal health. The second is surveillance, and I think once we start taking care of these babies once they're born, thinking about what are the different areas of health and development that we need to be especially tuned into for babies who have had growth restriction or for gestational age, with an eye to their growth, their feeding, and their neurologic development. And then early interventions for those who show us signs that they need some extra help. And it's not just necessarily early in life, but later, particularly when children enter school age, when some of these more subtle findings of executive function problems and behavior and attention problems might present themselves. So with that, I would like to say thank you, and I will turn it back over to the host.
Thank you, Dr. Litt. Wonderful, Jonathan Yair. We're going to bring you back on. Fabulous. I'm going to start you both off with this. Is there an increase in fetal growth restriction with IVF conception?
I guess I'm going to guess that question is more towards me. The problem is it's very hard to tease out comorbidities, right? So you have age as a comorbidity, other underlying medical conditions when women are a little older. So it's hard to say. Put it this way, I don't personally manage those twins different from other twins.
Right. Okay. Thank you. And we have to think about what you just said. So, okay. Jonathan, I'm going to share a slide that you shared.
Okay.
Because this one kind of blew me away. So if you can, just go ahead and explain this slide again, and then I want us to talk about it.
Okay. Oh, so these are the different areas that can be impacted, different areas of health that can be impacted in neonatal life as a result of growth restriction in utero. And
so any one of, excuse me, I'm sorry, go ahead.
Yeah, no, I was just gonna, I won't go through each one again, but to say that there are many organ systems that can be affected: cardiovascular, respiratory, neurologic, and then really endocrine are sort of the big ones, but certainly others as well.
Well, to see this all together, one of these can change a family's life.
Yeah.
Two of these can change a family's life. I mean, this is really major stuff for the family, for the child, for the parents. And it really does. I want to thank you for this slide, because it really does affect us, when we're thinking about this and the downstream effects of something that this slide is very intense. So I
Mm.
just wanted to
Mm.
show it again
Yeah.
and say thank you.
Oh, sure.
What about catch-up growth and neurodevelopment outcome?
Yeah, that's an important question, and that's one that I actually don't unfortunately have an answer at the moment. So we know that in fetal life, typical growth is important. Typical head size and we think brain size growth are important, and that's certainly true in infancy, um, and early childhood. Um, I have not seen literature supporting that those outcomes that I mentioned, sort of the later part of my talk, thinking about particularly the cognitive and behavioral kind of consequences of growth restriction, have been impacted by catch-up growth, the rates of catch-up growth, or have seen those outcomes sort of stratified by the children who have caught up and who haven't. And I think that's a vitally important question. And I think that the person who asked that, because I think that's an important area of research. What we know is that the kids who catch up faster or too fast, and we're still trying to sort of figure out what that means,
Right.
have worse health outcomes. It's not clear that those are related to worse developmental outcomes.
Okay. All right, I'm going to take my time and read this one now. Some centers check growth, Yair, in monodi twins every 2 weeks instead of 4. Your thoughts?
Well, I don't want to badmouth any colleague, but I think in the absence of fetal growth restriction, it could be a bit much. Now we do scan them every 2 weeks, but not necessarily for growth every 2 weeks. Meaning I think most, and I think this is true for most centers, at least the ones that I know, that do growth assessments every 4. Of course, if there's a trend or something else, yeah, you can do it more frequently. But I think doing a growth assessment every 2 weeks is, at least to me, seems a bit excessive, but maybe those other centers have a good reason to do that.
No, thank you for that point. Do you know of any studies or data on late preterm or near-term infants that may have had maternal prenatal treatment or concern for FGR or evidence of fetal malnutrition, but were not admitted to the NICU? I can read that again. It's a late preterm or near-term infants that may have had maternal or prenatal treatment or concern for growth retardation or evidence of fetal malnutrition, but were not admitted to the NICU.
I I can't speak to the treatment piece of that, right? The fetal treatment piece, but certainly there are babies who, as Dr. Blumenfeld said, who had concerns for fetal growth restriction, are born and are not small for gestational age, right? The two are not the same,
Right, right.
who go on to be perfectly healthy and have typical postpartum experiences and go home with their families and don't have any of the things that I mentioned. Um, there are appropriate grown infants who have some of those things, right? So it's a little hard
Yeah,
to
yeah.
answer that question, but beyond that. And I don't know if part of the question for you, Dr. Blumenfeld, is that is it possible to achieve a healthy, well-grown status after fetal treatment for
Yeah,
twins?
I'm not sure what fetal treatment
Yeah,
is.
I'm not, yeah, that's fair.
Um, one thing that comes up periodically is you'll have a fetus that is labeled as growth restricted because somebody gets an estimated fetal weight or an abdominal circumference of 9%. And then they come back a month later and the estimated fetal weight in the abdominal all of a sudden is 11%. So it goes from
Mhm.
9%, 11%. And the counseling when it's 9% is doom and gloom. And the counseling at 11% is, oh, your baby's perfect. And I think we just have to be a little cautious when we sort of draw these lines in the sand and to help patients understand the limitations of technology and really like 9th and 11% sort of the same thing. Um, and so it's not that all of a sudden we went from a very, very pathologic process to everything is perfect. And that is something that we see a lot. So it's not necessarily that somebody received therapy, but like when you scan a lot and you have these sort of cases that are hovering around that 10th percentile, and we do set these arbitrary, not arbitrary, we do set these lines in the sand.
Right.
Um, so that's something that I think that's important to keep in mind.
You just brought back days of antepartum testing, right, of the AFI, and 1 point this way,
Yeah,
you can go home. 1 point this way, let's get you upstairs and admitted.
yeah,
So,
exactly, exactly.
yeah, yeah. For the International Society of Ultrasound and OBGYN, how is genetic potential determined? I don't even know what that means.
Yeah, I'm not sure if they mean if the person asking the question really means genetic potential, but I think it goes back to that idea of just the I gap, which is the growth potential. That's, if we substitute genetic for a combination of other things,
Oh,
right? Like a
right.
combination of the
Potential. I think you're
inherent,
right.
yeah,
Yeah,
yeah. I mean,
yeah,
I mean,
yeah,
I agree.
yeah.
Right now, they don't take that into account. Meaning, there's no, and neither does SMFM or ACOG. Like, there's no, oh, what's the size of the parents, or what's the size of the egg donor, or whatever it
Right.
might be, right? And we say, oh, what's the race, ethnicity, BMI, size, how small or large were the parents. Invariably these kinds of things come up and they say, oh, but when I was born, I was 8 pounds, or when I was born, I was also small, or, all of a sudden this vocal pedigree comes out when you start having those kinds of discussions. Again, personally, I do like that concept and philosophy. I hope for more studies in this area, because if we can get to a point where we can use the fetus as its own control in terms of the growth potential, whether you want to call it genetic or otherwise, I think we'll have much better accuracy, or at least be able to delineate truly pathological from what used to be called and still is constitutionally small, like a baby that just, okay, it's small because the parents are small, or the egg donor, whatever it might be. I think that's what the person means. The other thing is we are starting to do, and I think this is already pretty standard around the world, is
Yeah.
third trimester amniocentesis to look for underlying genetic diseases. So using that concept of, okay, what does genetics really mean? And especially in the age of NIPT, where a lot of patients hear, oh, your baby's fine genetically because he had an NIPT test, where, okay, fine, so the baby doesn't have Down syndrome, trisomy 18 to 13, great. But there are 3 billion base pairs of AGCT, and NIPT is not the end all be all. So we're certainly doing and seeing, and certainly this is true from around the world, where, especially with early onset fetal growth restriction, amniocentesis, not for a karyotype, and you know, microarray and soon exomes and other things, that I think that's going to become a lot more prevalent, where parents might not be as eager to do an amnio early on, but you have early onset growth restriction, and to rule out associated abnormalities, I think we will see an increased frequency of amniocentesis in the third trimester to rule out an underlying genetic etiology. And the yield on that is actually not so low.
Oh,
I mean, it's probably, depending on the test you do, for early onset, probably on the order, if I had to pick a number, between, let's call it 5 and 10%, meaning 5 and 10% of that. And let's not forget CMV. I mean, anecdotally, I can recall not one and not two cases of undiagnosed CMV in the third trimester, where it's, idiopathic fetal growth restriction. We're following them with Dopplers, and we're so focused on the placenta. And sure enough, the baby has CMV. And an amnio would help with that as well.
I have a feeling I'm breaking up. I don't know if everyone's seeing that. And
Mhm.
needless to say, you don't need to see me on camera, but I can't even turn off my camera. Can you discuss the intergenerational effect of growth restriction? Mothers who had a low birth weight have a higher chance of delivering a smaller baby. Intergenerational effects.
Yeah, I mean, I think on the prenatal side, it's definitely an interesting concept. Um, it's one where not, unfortunately, not everybody knows what their size was, and it's kind of hard to study and to tease out
Right.
confounders, right? Where they lived, what kind of size, what is going on. Obviously, the technology that we have today was very different from previous. We don't have great archives. I think it'd be really interesting to study in a country where you have really, really great record keeping, right? Where you can go back to, 30, 40 years ago, and see what it is, and maybe even go back further to see. I mean, I'm sure there's some truth there. I think it's an area that'd be pretty hard to study just from confounder perspective and other things. And it's not anecdotally, I can tell you that, if we have a diagnosis of fetal growth restriction and somebody says, "Oh yeah, but I was also small," yeah, it might reassure us a little bit if the Dopplers are normal, but we wouldn't say, "Oh, that's what it is. See you
Yeah, we're
later.
out of
See you at
here.
delivery." We
Yeah,
would still monitor them and to make sure that it's
right,
not something else.
Mhm.
right, right. No, I think that's it. I have this one. It's more of a comment. We have folks asking Dr. Litt for your 2024 paper. So if you wouldn't mind maybe emailing me the link, and then we can go ahead and send it out to them in a message to the attendees, if that's okay with you.
Sure, happy to.
Okay, okay. The two of you, fabulous, fabulous, fabulous. Thank you, thank you, thank you for joining us. And we will be looking to having you back. You're both lovely to work with, and that means a lot to us. So thank you.